is always remove the prostate. That is radical prostatectomy, where we remove prostate, surrounding lymph nodes, fat, those ejaculatory ducts, seminal vesicles are removed. Bladder is not removed here, okay? Just prostate. Other option is radiotherapy. Radiotherapy can be applicable in various ways, like you can use radiotherapy as a sole treatment, only radiotherapy. This is known as radical radiotherapy, which is equivalent to radical prostatectomy. I'll explain. Wait. We can use radiotherapy after surgery, known as adjuvant radiotherapy. We can use radiotherapy as a palliative care. That is, if a patient has a cancer prostate patient with bone metastasis, you must have to give radiotherapy to the bone, otherwise bone will fracture. A cancer prostate patient with brain metastasis, always give radiotherapy to the brain. There's another way of managing the cancer prostate is androgen deprivation therapy, ADT, or we can also say hormone therapy. Cancer prostate is hormone dependent cancer. That means the growth of cancer depends on presence of testosterone, because as you know, these cancer cells arise from the glandular epithelium, and the glandular epithelium are hormone sensitive. So cancer is also hormone sensitive. That means if the testosterone is still present in the male body, the prostate size plus cancer size both increases. That's why if we can decrease the concentration of testosterone inside the male body, then the cancer size will decrease. Okay, this is applicable for metastatic cancer prostate mainly, but also we can give these drugs in combination with surgery or radiotherapy, depending on situation. But mainly this androgen deprivation therapy is applicable for metastatic prostate cancer. We have some chemotherapeutic agent, especially used for metastatic cancer prostate, like docetaxel, cabazitaxel. Watchful waiting or surveillance. Sometime, even if a patient has indication for surgery, we cannot do surgery because of other disease or other problems, like a patient of age 70 years with cancer prostate, localized disease. You can go for surgery. But if the patient has other comorbidities like recent onset of MI, angina was there, okay, uncontrolled hypertension, and so many other problems, in that case, you can do surveillance. Palliative care, whenever there is a metastasis to the other organs, then we have to add some palliative care. Radical prostatectomy. When to do that? Localized cancer prostate, it may be T1 or T2, localized cancer prostate, life expectancy more than 10 years. Roughly, we do surgery up to 75 years and having no other serious health issues. Okay, they might have some mild disease, but not severe disease. Then in that case, apparently healthy, then you can do radical prostatectomy. We can also try radical prostatectomy in the case of locally advanced disease, especially in the case of T3 disease. Okay, you can do that. You can do radical prostatectomy. But once it is a locally advanced disease, after doing prostatectomy, you have to add some therapies like adjuvant ADT or adjuvant radiotherapy can be added to have effective outcome. And you can do it by open technique, you can do it by laparoscopic technique, and also very commonly done in Western countries by robotic technique. This is bladder, this is prostate, rectum, these are pelvic nodes, small vesicle. Okay, so we remove prostate, including prostatic urethra, pelvic node, surrounding fat, seminal vesicles. So these are removed. After removing the organ, what we do, we stitch the bladder neck with bulbar urethra. Stitch it here. Okay, fine. Sphincter intact. So the complication, obviously, bleeding is there during surgery. But what are the late complications that may arise? Erectile dysfunction. Erectile dysfunction, because there are very fine neurovascular bundle at around posterior surface of the prostate. Okay, that supplies the penis. So whenever you do radical prostatectomy, there is a chance of damaging these neurovascular bundles of penis. Okay, and this is more common in open technique than laparoscopic than robotic. Okay, so if you do a robotic technique, the surgery is very fine, and these neurovascular bundle can be saved. Sphincter damage lead to incontinence, stress incontinence. That is, if the patient cough, if the patient laugh, sneeze, there may be leakage of urine. As there is a anastomosis between the bladder neck, okay, bladder neck and urethra, there is a chance of stricture. These are the common complications that may arise after doing radical prostatectomy. So if you do a robotic techniques, then these complications are less. See, this is what radical prostatectomy means. We remove the prostate, surrounding fat, lymph nodes, pelvic lymph node, small vesicle is removed. After that, we stitch the bladder neck with bulbar urethra, and the urine can pass through it. Robotic setup. You can see patient is lying in bed, and the assistant is putting the robotic arm inside the pelvis. These are the robotic arms, okay, and this is the main surgeon who is seeing everything through this monitor here. They move those joysticks to control the movement of these robotic arms, okay, and the assistant will see at this monitor and help the main surgeon. So this is very precise. Surgery can be done because robotic arms can be rotated 360-degree. They can be moved very fine, such that those chance of damage of those neurovascular bundle, chance of damage to rectum, chance of damage to sphincters are very less due to the very fine movement of these robotic arm. Radiotherapy. So this is patient. This is bladder. Prostate cancer is there. We can apply the radiotherapy from outside to focus on these cancer cells, okay, and kill those cancer cells. This is known as EBRT. EBRT means external beam radiotherapy. And sometimes we also can use the radioactive substance directly into the prostate, like seeds. Okay. Then this is known as brachytherapy. So radiotherapy is applied either as an external beam radiotherapy or as a brachytherapy by putting a radioactive seeds. To obtain good outcome, the best technique is external beam radiotherapy. This is also known as radical radiotherapy. Indication is same as radical prostatectomy. That is, patient might have localized cancer prostate plus life expectancy more than 10 years, that is age within 75 years. Okay, and no such other severe comorbid disease. Okay, so in that case you can do this. Plus also you can apply this radical radiotherapy in the case of locally advanced cancer prostate, especially T3 disease. And after that, after doing radical radiotherapy, you have to add some adjuvant therapy like ADT. Okay, what are the complications that may arise if you do radical radiotherapy? These radio waves are very focused. Still, it can cause injury to surrounding organs. The two major organs that can injure are bladder and rectum behind. These can cause radiation cystitis or radiation proctitis. Proctitis means rectal inflammation. Erectile dysfunction are not that common in compared to radical prostatectomy. Okay. This is external beam radiotherapy. You have seen radiotherapy is given through a machine from outside. We will focus the site of radiation by using CT scan, and then these focused beam are given to these cancer prostate, okay, from outside. And brachytherapy means we give these radioactive seeds, these radioactive seeds directly implanted into the prostate. And these radioactive seeds are iodine 125, palladium 130, and iridium 192. These are radioactive seeds that can be implanted. Better option is always external beam radiotherapy. Diagnosed as a case of localized cancer prostate. Okay. Now we have two basic options. You can go for radical prostatectomy, or you can go for radical radiotherapy. So which one to choose? Both are effective. For both patient, life expectancy should be more than 10 years. If fit for surgery, better to go for radical prostatectomy. Okay. If unfit for surgery, you can go for radical radiotherapy. This is one option. And another option is the patient can choose either radical radiotherapy or radical prostatectomy depending on his complication profile. That is, see, if you compare the complications, the radical prostatectomy may lead to impotency, right? So you can say erectile dysfunction. It may lead to incontinence, or it may lead to stricture. And here, it may lead to radiation cystitis or radiation proctitis. So, depending on these profile, plus the chance of recurrence is more in radical radiotherapy. So when you discuss everything with patient, then they can choose. See, whenever there is a metastatic cancer prostate, we use a therapy known as androgen deprivation therapy or hormone manipulation therapy. Before understanding that, we should know what is the physiology of male hormone system. See, this is suppose hypothalamus, pituitary gland, okay. This is testis. So the hypothalamus secretes hormone known as GnRH. This is gonadotropin releasing hormone, which acts on receptors in antipituitary gland, and after acting on these receptors, this Anterior pituitary gland release hormone known as FSH and LH, follicular stimulating hormone and luteinizing hormone. among these, the luteinizing hormone act on testis to release testosterone. Okay, testosterone. Okay, and this testosterone is converted to dihydrotestosterone by the help of 5-alpha reductase enzyme. And this dihydrotestosterone act on prostatic receptors such that the growth of prostatic cell as well as cancer cells. Okay, the cancer cells and the normal prostatic cells both grows under the influence of dihydrotestosterone. So you can say that prostatic cancers or cancer cells are hormone dependent cancers. So prostate cancer is a hormone dependent cancer. The adrenal gland in male also secretes little amount of testosterone, which is converted by 5-alpha reductase into dihydrotestosterone. Maximum amount of testosterone is secreted by testis, not adrenal gland. Okay. So this is the normal physiology of male system: hypothalamo, pituitary, testicular axis. As we know that the cancer cell as well as normal prostatic cells both are dependent on testosterone. If you block the testosterone supply to these prostate, then the prostatic cells, normal prostatic cell as well as cancer cell, both will regress or it will not grow. So this principle is applicable for metastatic cancer prostate. We don't give this medicine or this therapy for localized cancer prostate, because eventually these drugs will be resistant, because the cancer cell will modify itself, receptor modification and other modifications that lead to resistance to these drugs. That's why these drugs are not used as a primary treatment for localized cancer prostate or locally advanced cancer prostate. Rather, they are used for metastatic cancer prostate. So what are the options that we have for decreasing the testosterone supply? One is we can remove the testis. Bilateral orchidectomy or orchiectomy. Remove both testes. If you remove both testes, then it leads to sudden lack of testosterone, and obviously there will be lack of DHT, and cancer prostate will regress. But some male doesn't like this. For that, we have another option. Can we block this action of GnRH? If we can block GnRH at this level, then LH will be not produced. That means testis will not produce testosterone. So similar action, right? So we can do that by two type of drug. One is known as GnRH antagonist, a drug that acts exactly opposite to GnRH. That is, this drug will block the receptor sites such that GnRH cannot work. We also have another option known as GnRH agonist. Agonist means it acts similar to GnRH, but the affinity to receptor is more than normal GnRH, and after a while, after a few days, it will not work. It will just alter the configuration of receptor and it won't work. So the agonist means similar, right? That's why whenever you use GnRH agonist for few days, for few days, there will be increased testosterone level. Testosterone. This is known as flare-up phenomenon. That is due to use of GnRH agonist to block the receptor. Initially, as it is agonist, it will increase the secretion for a while, and then later on, the receptor will be inactivated and it will not work at all. So this blocking the action of GnRH either by agonist or antagonist is known as medical castration. What is castration? Castration means removing testes, right? So this is surgical castration. Castration, as we have removed it surgically. Medical castration. That means we have given the drug so that it blocks the activity of GnRH, leading to no testosterone production from testes. That's why it is known as medical castration. Surgical castration or medical castration. Androgen receptor blocker. Okay, or we can say anti-androgen, same thing. But the problem is when you use these receptors blockers, then after a few months, the cancer cell will alter the configuration of receptor, such that after a few months or a year, the drug will not work because of change in the configuration of receptors. That means the patient will develop resistant. We use this drug in combination with medical or surgical castration, but we don't use it as a single drug. Okay? Sometimes we need to block the testosterone completely. Complete blockage means here we can see we have to block the testosterone from two sources. One is from testis, fine. We can do that by orchidectomy or medical castration. But what about this testosterone? This one, that is very little amount, but is being produced by adrenal gland. So if you want to block that as well, then we have to use testosterone synthesis inhibitors. Example is ketoconazole, abiraterone. This drug will will block the synthesis of testosterone from adrenal gland. So we have these four options, right? One is bilateral orchidectomy, that is surgical castration. We have option for medical castration by using GnRH antagonist or agonist. We have androgen receptor blockers, and sometimes we need to block the synthesis of adrenal gland as well. So these all options are collectively known as androgen deprivation therapy, also known as hormonal manipulation therapy. Yeah. So see the drugs. Castration. Uh, Castration means basically we are decreasing the testosterone level from the testis. Okay. So surgical castration means bilateral orchidectomy. We do bilateral subcapsular orchidectomy. Or medical castration, either we use GnRH agonist like goserelin or leuprolide, or nowadays we can use GnRH antagonist, okay, with no flare-up mechanism, degarelix. Androgen receptor blockers act as at the site of prostate. So bicaltamide, flutamide, these are the drugs that we use. And androgen synthesis inhibitors from adrenal gland are ketoconazole and abiraterone. So drug that acts on pituitary gland, that is GnRH activity, goserelin, leuprolide, and degarelix are the common drug. Drug acting on adrenal gland, ketoconazole and abiraterone, common drug. Testicle, that is orchidectomy, and drug acting at prostatic cell, that is receptor site, bicaltamide and flutamide are common. Okay, let me give one more interesting example. Suppose a 72 years male diagnosed as a case of prostate cancer with bone metastasis.
Okay, this is the profile of patient. We give androgen deprivation therapy plus palliative care. After putting the patient in the ADT and palliative care, we follow up by investigations, scanning, and also by PSA. Initially, PSA was very low, but suddenly you found the PSA is increased suddenly. Okay, after a few years, that means what happened? You're right, recurrence. Why recurrence? Because of resistance to the drug. So when this happened, we give a term known as castrate resistant prostate cancer, or you can say hormone resistant prostate cancer. Now what to do, guys? So now we have to give second line drugs. So we have some drugs that acts for second line. That is, still the patient is a case of metastatic cancer prostate. The first line ADT was resistant. Now we have some second line drugs. Okay, and those second line drugs are docetaxel, cabazitaxel. These are anti-cancer drugs. Abiraterone, I will explain, and Spulacil T. These drugs are used in the different combinations. Okay, now treatment protocol. We have learned a lot, but you don't know when to utilize what type of management, right? So if the patient has localized disease means, it is either T1 or T2. That is, the cancer prostate is within the prostate. In that case, we have three options. One is radical prostatectomy, radical radiotherapy, watchful waiting, or active surveillance. If you can do this surgery, do the surgery, because surgery will remove the prostate such that the chance of recurrence will be very, very low. And it must fulfill some criteria, right? The life expectancy should be more than 10 years. Age is usually should be less than 75. And patient should be fit for surgery. Radical radiotherapy. This is also a very good option. Life expectancy should be more than 10 years. Okay, is usually less than 75 years, and as this is not a surgery, so general fitness is okay. When the patient have localized disease, but they are not fit for these radical radiotherapy or radical prostatectomy. Suppose the life expectancy is less than 10 years, or you can say age is usually more than 75 years, or not fit for surgery or even radiotherapy, very ill patient. In that case, we say, okay, let us wait and watch, or put them in surveillance, such that when the patient develop metastatic feature, so treat when they develop metastasis. Usually, this is the principle. And you may think, so why you're waiting for metastasis? Because see, these patients are not fit for surgery, and the life expectancy is also less. And remember one thing, in the case of localized disease, if size is less than 3 centimeter, they grow very slowly. Even after doing radical prostatectomy or radical radiotherapy, sometime we may need to add ADT in some cases only. Okay, so when the cancer involves these structures, surrounding structures, this is known as locally advanced cancer prostate. What are the options that we have? We have two options in this case. One is you can straight go for radical prostatectomy. Okay, and see, as this is the case of locally advanced, some cancer cell must be in surrounding area, right? So we wait for histopathological examination report. We wait for report. Then depending on report, we add some therapies. Okay. If the report says surgical margin is positive, that is, this was the specimen of prostate, we have removed it, and they have checked that the margin of the resection margin was still having cancer. That means some cancer cell was already inside the pelvic cavity. That means you have to add something, that is add local radiotherapy. Add radiotherapy to the pelvic area. Why? To kill those remaining cancer cell inside the pelvis. If the report says, okay, margin is negative, no problem, but as you know, we send lymph node along with the prostate, right? When we do radical prostatectomy, we remove the lymph node also. And if the report says the lymph node is positive, if the pelvic lymph node is positive, you have to add ADT surgery. If the report comes both positive, that is margin is also positive, lymph node is also positive, then give both radiotherapy plus ADT after surgery. Sometimes what happens is the cancer is a bit large, already involving the rectum and surrounding structures, and you cannot do a radical prostatectomy. You cannot do that. In that case, what we do, we give radical radiotherapy to pelvis, okay? And as we haven't removed the prostate, after giving radical radiotherapy to prostate, long-term ADT should be added. Metastatic means we have two options. One, always we give androgen deprivation therapy. We always do that. Plus, we always do palliative care. If he is fit for chemotherapy, the best option is surgical or medical castration with chemotherapy. If he's unfit for chemotherapy, then you do surgical or medical castration with anti-androgen. Anti-androgen means androgen receptor blockers, that is bicalutamide and flutamide. Okay, if you are doing a medical castration, we have two options for that. One is GnRH agonist, other is antagonist. But if you are using agonist, like goserelin, the problem of this agonist is there will be rapid rise of testosterone. This is known as flare-up. Then what's the problem in that? The problem is, suppose a patient is having cancer prostate with bone metastasis. And in that case, if you have used GnRH agonist, then sudden increase in this testosterone causes increase in cancer cells activity also. That means it will be going to destroy the bone more rapidly, and it can cause bone fracture. So a patient who was stable, by using drug, you made it unstable and fracture of vertebra, leading to spinal cord injury. That's why if you are using GnRH agonist, there's a chance of testosterone flare up. To combat this situation, we always add flutamide for 7 days, and then we continue as GnRH agonist. So this is a bit nice to know thing, but if you don't remember this, no problem. And obviously, this is the case of metastasis, so you have to take care of pain with morphine, give them psychological support, and suppose sometime in the case of cancer prostate, these cancers may grow along the bladder neck and obstruct the bladder neck, like this one. Patient of cancer prostate may complain to you having difficulty in micturition. In that case, what you can do, you can just do TURP. TURP is not a treatment of cancer prostate. It is a treatment for relieving the obstruction caused by cancer prostate. So you can remove this prostatic tissue such that the pathway will be clear, the patient can pass urine. And as I've already told you, the bone is the most common site of metastasis of cancer prostate. So you have to take care of bone very specially. So to prevent the fracture of the bone, you have to give local radiotherapy. So this is vertebra, the most common site of metastasis, and it contains spinal cord. So if you don't manage these cancer cells, then it will cause fracture of vertebra, leading to spinal cord injury or spinal nerve injury, right? So what to do? Apply local radiotherapy to these bones. One, radiotherapy. Okay, give some drugs like denosumab or bisphosphonate, which makes the bone strong. Also prevent fractures, and also calcium and vitamin D supplement that provide calcium for bone strength. So these are the management specifically designed to prevent fracture of the bone and vertebrae in the case of metastatic cancer prostate. Screening means when we detect any disease, including cancer, before producing any symptoms. If you diagnose a patient of cancer prostate in very early stage, even before producing symptoms, and if you do a surgery or radiotherapy, then the chance of survival will be very, very high. So for cancer prostate, we have a method where we do DRE and serum PSA analysis. Then I'm using AUA guideline. AUA means American Urological Association guideline, where it says that if the man is below 40 years, there is no need to do any screening, no need at all. If the man is from 55 to 69 years, then do always routinely do screening every 2 yearly. What to do? Same, DRE and PSA. What about the age group between 40 to 54? Normally we don't do screening, but if the patient has a high risk, characters like having a positive family history, having some BRCA2 positive. So when they have these high risk, factors, then you can start screening even before 55. And men at the age more than 70 years or whose life expectancy is less than 10, then we don't go for screening of that male. If we found any abnormality in DRE or PSA value, then you have to confirm by biopsy. The screening. A 50 years old male with positive family history of cancer prostate, he came to you for screening. What you will do? Obviously, we will do DRE and PSA. Okay, let me explain this question, then you will understand. 85 years old male, he underwent TURP for BPH, not cancer prostate, for BPH. And then on histological examination, it was found that there were some foci of cancer. That means this is the case of localized cancer prostate, either T1A or B. So now, what are the options for localized cancer prostate? The options are endocrine therapy, no. Hormone therapy, no, because these are for metastatic. So we have either B or D, right? Either we go for radical surgery or we do nothing. See, the age is very old. So in very old patient, we don't go for radical surgery. We will do wait and watch policy. That is, no further treatment. Same thing, a 50 years old male diagnosed as BPH, underwent TURP and found some foci of cancers in that histological findings. Still, this is T1A or B, that is localized cancer prostate. Here, the option is hormone therapy is still wrong. Orchidectomy means these are done for metastatic cancer prostate. So either we go for no treatment or radical. As the age is 50, the option should be radical prostatectomy. If you do radiotherapy to a cancer prostate patient, then always check for the recurrence by doing PSA. This is the case of cancer prostate with metastasis to the vertebra. So it's the case of cancer prostate with bone metastasis. Okay. So metastatic cancer prostate is managed by ADT, also known as hormone manipulation therapy. Answer is D. Spilucel T is a drug that is usually reserved for castrate-resistant prostate cancer. We use it for cancer prostate. Yes, a localized cancer prostate with life expectancy more than 10 years is the ideal candidate for radical prostatectomy. See here, a 65 years old male with LUTS is there, and DRE shows non-tender prostate. Obviously, we think of either BPS or cancer prostate. We did a lot of investigations and found PSA was high. So this is a high PSA value. So now you must think of CA prostate, and the pelvis, MRI pelvis shows there is a hypointense mass in the prostate, and on biopsy we found the cancer prostate with Gleason grade 9, and we did metastatic evaluation. Everything was normal. So my diagnosis is localized cancer prostate, and management is obviously the options that we have are either radical prostatectomy or radical radiotherapy. As the age is 65, there is no other problem. Best option would be radical prostatectomy. 68 years old male with LUTS, and see over here, there is a recent onset of back pain for 1 month, right? This is alarming. DRE shows enlarged non-tender hard prostate. So this is very much likely to have cancer prostate. BPS is very rare option. And we did investigations, found PSA is very, very high, 20 nanomole per ml. And the biopsy confirms it is a cancer prostate with Gleason grade 7. MRI shows there is a hypointense mass in prostate. During the metastatic evaluation, we found the alkaline phosphatase was high. So a patient having a back pain, PSA 20, and alkaline phosphatase high, you must do bone scan. These are all indications of bone scan. So this is the case of obviously you can see multiple hotspot in the bone. See, this indicate this is the case of metastatic cancer prostate, and we know how to manage this, right? We have ADT in combinations and palliative care. These are the reference I have used.